The 5th International suPAR Symposium was held in 2014 at the Academic Medical Center University of Amsterdam. This year's topic was suPAR and its clinical use. It was an exciting 1.5 days in the historic Trippenhuis building in the heart of Amsterdam. With many high-quality presentations and productive discussions on the latest findings from recent studies with the biomarker suPAR.
Did you say that some biomarkers, if let's say you take two biomarkers, if they're negatively correlated rather than positively correlated, then they add more value?
If they are not correlated at all?
In all the studies that have been made, when you put them into multivariate analysis, suPAR keeps coming out with additional information.
The future is a combination of several biomarkers to improve the prediction of outcome.
To reduce the decision delays, maybe we should add simple diagnostic tools that actually changes the care for these patients. It gives a simple answer, yes or no, do this or do not this. Start treatment, do not start treatment. Take this patient to the geriatric ward, or take it to the ED, or take it to somewhere else.
suPAR cannot be influenced by any doctor, by any way you admit a patient to the ICU, or any way you are looking at a patient or treating a patient. It's a value that comes in, and it's there, and it's stable over days.
After a great first day, once again this year, you could get your suPAR levels checked. And of course, we held a suParty where everyone could get to know each other across borders. The following day started with presentations of 15 new or recently published studies. Some strong points came across.
But when we saw this, we were stunned. The cutoff value of 10.58 showed 100% sensitivity, specificity, and whatever we wished. To distinguish children who are at risk of having hospitalization treatment longer than 10 days. And I need to add that even the youngest children, if the pneumonia is treated right, won't need hospitalization and won't need antibiotic treatment longer than 10 days.
suPAR is associated with NT-proBNP and an increased incidence of heart failure, but not to atrial fibrillation.
A combined use of suPAR and plasminogen activator inhibitor 1 would be an even stronger tool for predicting which HIV-infected patients are at high risk of developing cardiovascular disease.
It has been truly exciting. I think there were so many indications where we see it could actually influence clinical decision-making. For instance, the children with pneumonia, the prosthetic joint infections. We saw that suPAR might have distinctive function in high-risk patients like type 1 diabetes, HIV-infected patients, that you might be able to detect the patients that are likely to have a problem in the near future. So this could indeed influence clinical decisions.
And finally, the latest experiences from implementing suPAR in clinical use were shared.
But again, I think it's very important when you introduce new biomarkers, then you will discuss with your staff that this is the right thing to do.
So in Switzerland we have situations where we do interviews, come at 3 o'clock in the morning, one assistant doctor, the other one's asleep, small hospital. So I think in every setting, in every country we have situations of affluence and not affluence. This depends then on the use.
The readmission rate is reduced 1 percentage point from 7.5% to 16.5%. The department saves 284,000 euros per year.
Yes, I would like to thank the keynote speakers who gave some of their precious time to give us the lectures. I would like to thank the researchers who wanted to share with us their data. Thank you very much for that. And I want to thank the audience, of course. The scientific committee, we did a lot of work, and the help of Helle and her team in taking the right decisions and taking the right spots. Thank you very much.
See you in Madrid 2015.